first of all, to take a bipolar disorder history and then to risk assess and decide if the patient needs management, needs inpatient admission. Sorry. Fine. So we'll go. As always, if you have any questions, you can always ask them. And yeah, I'll leave like 2 minutes in between the session to answer any questions, or probably more. Um, Fine. So taking a history of a bipolar disorder patient. This again, like I said, you will first confirm bipolar disorder, or you have like a suspicion of bipolar disorder, and then you'd always want to assess risk. We'll go through some differentials, and then we'll talk about some investigations, and then finally we'll go in a bit of as well, just because I think it will be useful for your written papers. And also, it's a common, if you do have a psych job coming up, it's a very common condition you will see both in your clinics and in your on the inpatient wards. So it'll be a good, I think it'll be a good thing to just know a bit about the management as well. Perfect. So we'll go through the history first. So again, in any as you would in any general psych history, because obviously like start by asking about things like their mood, their interests, their hobbies, how have their thoughts been, any delusions or hallucinations. So because when you go in, you may have a prompt on the door which says, oh, this is a 36-year-old female who's come in. She's been having some delusions, or she thinks that she's under the impression that she has some kind of superpower, or the prompt may be that she's not been eating and drinking for a week now. Could you please assess her? So when you go in, you don't know for sure, of course, that it's bipolar, right? If the prompt is that she's not eating, you could be thinking of depression, of mania, bipolar, yeah, in the psychiatry realm of things. So the first thing is you always want to assess their mood, yeah? So you can ask questions like, how has your mood been lately? Do you find... So the second question is actually quite key, because it's a common misconception that people who have bipolar disorder, when they're having their high phase, they are just extremely happy. Okay? Now, this might not always be the case. In fact, majority of times in their high phase, yes, they are productive, yes, they are low in mood, but they're actually very easily angered and irritated. So it's very important to ask them, oh, do you find yourself getting more irritated than usual, or have you noticed any change in your temperament, for example? So yeah, it's key to not only ask mood in general, but also to just kind of ask specifically about them being irritated, because actually that would again as well, because if they're constantly on edge, and if they're constantly getting stimulated and irritated, and if they have no inhibition, it can again lead them to risky. So just important to kind of ask that bit specifically, because yeah, especially in medical school, it was a very common misconception that the highs of bipolar was just simply patients being really elated and happy, which is not always the case. Fine. So after you've covered your mood, then you want to go on to things like, in a full psych history, you would interest. So have you lost any interest in things that you used to enjoy? In bipolar disorder, it will be the opposite. So if they're having their manic phase, it will be like, oh, have you had any new? So you could always tailor those questions accordingly. So do you have any new hobbies, or have you taken up anything new recently? So that's in your anhedonia and loss of interest bit. Then you want to talk about how their thoughts have been. So you can ask them things like, oh, do you find that your thoughts jump about a lot? Are you having a lot? And they will actually jump on that if they are, and if you do get that vibe that, oh, this patient is just constantly like not in one place, so they may be pantsing all about the room. And if you just find, if you just think that this patient may have a manic episode, ask them about their thoughts as well, quite specifically, that do you find that your thoughts jump about a lot? And they'll tell you, yes, they've been having 100 thoughts a second, and they've been thinking about 10 things at once. So this is like a manic episode. Then you want to ask them specifically about delusion. You can ask them things like, what do you think of yourself as a person? Do you think that you have any special talents or any special powers? And then they can tell you, oh yeah, in keeping with whatever delusion they're having. For example, they may think that they are a famous YouTube singer and it hits 1 million views, for example. This is a few things that I've seen from my experience, but it can be anything. So based on the narrative based on what they're saying, you can ask questions accordingly. And then, yeah, always good to ask, have you seen or heard anything in the news that has any special meaning to you? Has anyone important or famous spoken to you recently? And what did they say? If it sounds risky, ask them, oh, have you told this to someone? Have you confided in someone? Are you going to act on what they're telling you? So again, just this is in this station, it's very key to notice what the patient is saying and how they're behaving, and ask questions accordingly. In both in OSCEs and real life, patients when they're having their manic episode, they'll be very restless. Okay, so in their room, you may find that they won't be on their chair, they'll be like walking around. It'll be quite difficult to it might be difficult for you to get your questions in, because they will just kind of going on in their head. So it's very important to keep bringing them back. So you can always be like, oh, please have a seat, let's have a chat. I can see that but I would really appreciate if you could just sit down and talk to me for 10 minutes. So these kind of prompts are really good to just keep in mind as well, because it is very easy. Because I remember when we had our it was very easy to get thrown off by a patient who was just constantly restless and walking up and down the room and, yeah, not focused. Yes, so sorry, I am also deviating quite a lot, but if you have any questions, feel free to ask. Fine, so after you've spoken about delusion, mood, just asked about their general hobbies and interests and how they've been in the last 2 weeks, you can then go on to risk. Okay, so introduction, so this and then I'll have another slide on risk assessment full, which I'll just go to, where you could just kind of ask them, oh, have you been doing things that you wouldn't usually do, or more explicitly, if you want to go more specific, you could ask them, oh, would you say that you're more daring than most people, or have you done things that are more extreme than most people would? Sorry, I'm just going to close the door. Okay, so that's, and then from there you could go on to completing your risk assessment. So I've just divided risk assessment into, so you don't forget, but I think if you ask 2 or 3 of these in an OSCE setting, it should be fine. In real life, obviously, just try and cover most of it. So sleep and food is important, because oftentimes, like I said, because they're so restless and they want to do 100 things, they often compromise on their sleep, especially, but also food. So sleep is actually very key. I would not miss out sleep in a bipolar history, oftentimes because majority of patients, I think everyone I've seen in my psych job, and even from textbooks, like 80% of patients they have less than 4 hours of sleep when they're having this much. And actually, it's a bit like when they have that lack of sleep, or when they don't sleep, it can even bring about a relapse. So if they have long-standing bipolar disorder, they've been in remission for a while, and let's haven't gotten enough sleep one night, it can actually even trigger a relapse. Okay, so it's very important to ask about how their sleep has been now, and how their sleep was as well when all this started. So sleep is one of the key things, because first of all, it can trigger a relapse, and also patients who do have bipolar disorder, they will virtue of all the things that they're doing. And the third thing is, having a good night's sleep can actually be one of the best recovery methods for them. I've seen patients improve a lot just after having a good night's sleep. Okay, but it can be very difficult to get them to sleep. Yeah, so active and they feel so productive and they want to do so many things, and they can also be very agitated. But yeah, sleep is very key, so I would not miss out asking that question. Okay, so, and then also ask them about their food intake, because that's also, it comes under risk to self if they're not eating and if they're not drinking. So yeah, I would ask about sleep and food, definitely. Ask them about libido. So you can approach it, oh, this may be a sensitive question, but have you noticed a change in your sex drive recently? And more importantly, are you having safe sex? Okay, because obviously risk of STDs is also a significant risk, both to themselves, and that's a good question to ask. Then forensic history, I'm sorry for all the typos here, by the way. But yeah, have you been in trouble with the police lately? And also, it's also a good question to ask if they're driving, because they're driving on less than 2 hours of sleep. It's not safe for them and for other people. So I would ask questions about that. And then, again, I've just put spending in there just because in my experience, I've seen this a lot. It's a very common theme. When patients get these manic episodes, they often end up spending a lot of money. They can I mean, they can completely run over their credit limit and have to borrow their partner's cards. And yeah, so spending is definitely a common theme that I've seen. So it could be a good question to ask as well. How has your spending changed recently? Fine. So we've gone through a few questions. If anyone again has any questions, feel free to ask them. And then, like in all other histories, definitely remember to finish your history. So take a full comprehensive history, which means ask about past psychiatry history, which is again very key here. So you can always ask them, are you known to, so they can tell you, oh yeah, I'm known to Mylan Hospital, I'm known to Bethnal Green Clinic, or it just gives you, well, it just tells you that if this patient may have an established diagnosis already, and you just have to look at their notes and see what drugs they're on, so you can optimize management. You can ask them if they have a diagnosis disorder already, if by this point you're pretty sure that, okay, I think this is bipolar. If they do have bipolar disorder, so if they say, oh yes, yeah, I do have bipolar, you can also ask them, okay, have you had these episodes of highs in the past? When was the last time you had this episode? How many times have you had an episode where you felt really low in mood? If you have bipolar, has it ever been so bad that you had to be admitted into hospital? Yeah, so if they say yes, they do have bipolar, feel free to ask questions about their bipolar and how well it has been managed and how severe it has been in the past. Okay, that's past psychiatry. And then past medical, oh, I'm sorry, that's not supposed to be here. In past medical, you would ask them again, like if they have any other medical condition. If they do tell you in the past psychiatry that they do have bipolar and they are taking lithium for it, in your past medical history, you can always ask them, it looks really good if you do actually, that do you have any problems with your thyroid gland or any issues with the thyroid? Because lithium, like we'll also see later, can cause hypothyroidism, and it can also affect the kidneys. So if you know that, okay, they have bipolar disorder and they are taking lithium for a long time, you can explicitly ask them about their thyroid and kidneys, the examiner as well. And even in real life, it's good to always check the thyroid function tests if they are on lithium. So that's your past medical done. And then family history, again, it's important to ask if they have a family history of bipolar disorder. It will just, in a new diagnosis, it will just strengthen your case, because bipolar is actually one of those things that does, yeah, so I would ask about that. And then social history, again, very important. So who do you live with? What is the living situation like at home? Are there any kids at home, importantly? Again, remember your safeguarding and your safety netting. Your safeguarding. And then also, if they're using any recreational drugs, are they smoking more than, are they smoking more than usual, drinking more alcohol than usual? Kind of, yeah. So the rest of the history is very, very important on this station as well. And then, like in all stations, ice them, so find out what they think. So what do you think is going on with you? What do you want? So because this is actually when patients have an established diagnosis of bipolar disorder, they actually know that, oh, something is not right with them, and they will tell you that, oh, I think I'm a bit off, I think I should be admitted because I don't think I am safe. So in fact, they may actually have some degree of insight. So it's very important to ask them, oh, what do you think is wrong with you? And I wouldn't word it that way. What do you think is going on? And what do you want to come out of this consultation? Is there anything that you want specifically? So that's your E, expectation. And C, are you concerned about anything? So are you concerned about your safety? Are you concerned about safety of other people? Because often, like, many times they will not have insight. If it is like a full-blown manic episode, they will have zero insight. But in the early stages, they may actually still have some insight, especially, like I said, if they have an established diagnosis and they've had these relapses frequently, they will know that, okay, they should actually go into a hospital and stay there for a few days. So yeah, I know it can get a lot of, like, I mean, this can be a lot of questions to ask, but try and at least do risk assessment. And if I had to pick, I would pick risk assessment and ICE. Fine, perfect. Okay, and then moving on. So let's say, like, you've taken your history and now you know that, okay, this is bipolar disorder. You would still, when you finish your history, you still want to give a good list of differentials. And even in a clinical setting, you want to think about other causes as well and rule them out, okay, especially organic causes. So normally I would ask you guys, but since we can't do that now, so differential. So you want to divide that again into two categories. You can say organic causes and psychiatric causes. So organic causes of mania or of a manic episode would be drug induced. So a lot of drugs, a lot of recreational drugs can cause it. MDMA, for example. Any frontal lobe disorders can also present as like disinhibition, can appear like a manic episode as well. So frontal lobe dementia, delirium, cerebral HIV. Yeah. So these are a few causes. So you can always see if they've had an HIV test, for example, see if they have a history of dementia or delirium. Yeah. And then psychiatry causes. So bipolar disorder is one of the main ones. And then schizoaffective disorder can actually also present with what appears to be a manic episode. So like a combination of schizophrenia as well as affective disorders. So that's, again, like if an examiner asks you for a differential, I would definitely give a differential. I would not say, oh, this is definitely this. Okay, so even if something appears to be, let's say, like, I mean, if it's bipolar, I would still give some differentials. Oh yes, thanks. Sorry, I've just been told, but yeah, my laptop is low on battery. I will charge it. Thank you. Fine. So that's your differentials. Then we'll go on to investigations. Okay, so investigations wise, like I said, always categorize. So firstly, you want to take, this is strictly speaking, this is not investigations, okay, but in your full assessment, you want to take a collateral history from the patient's relatives, or if they're in a hostel, for example. So a lot of patients might be living in a hostel. So in that case, you want to talk to the warden or anybody else who's around. So collateral is key because it can help you identify exactly when the patient started behaving differently and what could have been a possible trigger. And then a collateral history is also important to assess the level of risk as well. So you could ask the relative, oh, have they been more violent, or have they been more aggressive towards anyone? Have they been eating? Have they been sleeping? So yeah, it's important to get a collateral exam in them. Physical exam is important, again, just to see if in the event that they have been self-harming or if they have been getting into fights. Yeah, it's good to do an examination. Urinary drug screen, again, because like we said, organic causes can include drug-induced manic episodes. So you want to do a drug screen on these patients. And then you want to do some blood tests. So for bloods, you want to keep in mind that eventually you some either a mood stabilizer or an antipsychotic. Okay, and obviously these drugs have side effects, and that's why we do want to monitor a lot of their parameters before they start taking the drug. Okay, so FBC, because antipsychotics can cause bone marrow suppression. So you want to monitor their FBC. So you want the FBC before they start treatment. And if they're on treatment, just to monitor that. You want usinase. Lithium can affect the kidneys. Okay. You want TFTs, again, because lithium can affect the kidneys. CRP, because just to see if they have any infection going on, again, because if they have low white cell count and an infection, that's not good. Narcotics can, like you all know, it can cause a lot of physiological problems like type 2 diabetes and obesity. So you want to know the fasting glucose as a part of like the whole metabolic syndrome. And then you want to know their LFTs just as baseline as well. Okay, so bloods, and then you could consider a CT MRI varying one of those frontal lobe causes. And if you're not convinced that this is like you think that this needs further investigation because there's a risk that this patient may have HIV or dementia or so on. Okay, so that's a list of your investigations. Always the key is definitely remember history, and yeah, so even if you have a clinic, for example, you may even call the GP. If you can't find anyone else to call, you can just ring the GP to find out more about the patient and see how they've been. See if they've moved recently from any other country, if they have a diagnosis of bipolar in any other country, because you may not have records. Fine, so that's assessment and investigations. Okay, coming on to management. I've just divided management into 3 topics. So firstly, so like I alluded to earlier, the key is to decide if they need admission, okay? Because if they need admission, then you need to arrange, because first of all, if they have insight, then it's fine, because they can come in as an informal patient. If they don't have insight capacity, then you would have to arrange for a section 2, for example, in which case, like, you'll need to arrange for an AMP. I mean, I won't go into that today, but it's important to first of all decide if they need admission. So let's say you're seeing this patient in your clinic. You want to know, oh, should I call the duty doctor, or should I call some other doctor again, confirm if they need admission? Because I don't know if you guys know this already or other point, but for a section 2 you need 2 doctors, one who is section 12 registered. So as an F1 you will not be, so you will need a senior rep to do that. You will need an AMP, and you may also need a family member. Okay, so at the end of your assessment in clinic, I want to first decide if they need admission. So this is where your risk assessment is very important. So I've just put a few things in which you will consider admission. So if they are at risk of self, so if they're not eating, not sleeping, and they're living alone, so you don't think they can look after themselves, that's a risk. If they are living with someone but they are at a threat to them, so either they're hurting them physically, that's a risk. If they, again, this is probably unlikely if they are having a manic episode, but if they're hurting themselves, harming themselves, having suicidal thoughts, that's the risk, so you will admit them. If they're having severe psychotic symptoms, so if they tell you that, oh yeah, I think I'm Superman, I think I have the ability to fly, and I live on a second floor flat and I've tried to jump and so on. If you find that they're delusions or if they're severely psychotic, are at a risk, you would bring them in. Then the third thing is increased psychomotor agitation. So if they're just really agitated and you think that they will not sleep and not recover unless they are in a psychiatry hospital. So yeah, that's your main assessment to see if they need admission. Then you want to look at acute treatment and then long-term treatment. So we'll just go a bit. So acute treatment. So if this is a new episode of bipolar disorder, you will consider things like oral antipsychotics. Okay, so this can be your haloperidol, risperidone, and olanzapine. And the reason you will not start them on a mood stabilizer, which is the main treatment for bipolar, mood stabilizers like lithium can take up to 2 weeks to work. Okay, so in the acute phase, you want to treat them with an antipsychotic. If they're already on treatment, so they may already be on lithium, then you want to first check with them, have they been taking it? In many cases, at least in my experience, the reason for the relapse is that they've stopped taking the lithium. Okay, so then you want to find out why they're taking it, if they're having any side effects from it, if that's the reason they've stopped taking it, or if it's they forgot to take it. So check compliance, very important. If they are taking it, and if you find that, oh, okay, I mean, if you're sure that they're still relapsing quite a bit, then you may consider adding another agent. We'll go through that in a bit. And if they are very agitated, you may even consider a short-term course of benzodiazepine to help with the agitation. Okay, so again, like I said, the 2 main things are antipsychotic. If they are on lithium, check if they're compliant, and you may consider adding another agent. If they're agitated, you can consider adding a short-term benzodiazepine. Then you want to look at other things, okay? So then you want to check their drug chart. If they are on an antidepressant already, you want to stop it. So they may have been given this antidepressant because they first had an episode of low mood. They went to the GP, depression, which is very fair, gave them an antidepressant. This was actually bipolar disorder. The manic episode just happened a bit later. You want to stop this because antidepressants will worsen mania, okay? So stop the antidepressant. If it's very severe, okay, and if they are unresponsive, so this is also like a catatonia where they just feel completely off. They're not talking to anyone. They're really unresponsive. They're not eating, drinking. They haven't eaten or had anything to drink for like 7 days, for example, and you think that just admitting them will not do the trick, then you can consider of electroconvulsive therapy. Okay, so bipolar disorder, a severe manic episode is an indication. So severe manic episode where they're not eating, drinking is an indication for electroconvulsive therapy. I haven't seen this, but it's something to keep in mind that this is an option as well. All right, so now coming on to long-term management. Fine, so your prophylaxis, so this is what the patients will be on, okay, to prevent relapse. They'll be on either lithium, which is probably the commonest, or they can be on sodium. The third one is carbamazepine, but that one is, I think, that's the least, that's probably the least one to be used. The commonest one is lithium, second most is sodium valproate. The key things to remember about lithium is it can take 2 weeks to work, so it's not very management. Also, like I said, you have to monitor their kidney function and their thyroid function, because it can cause kidney impairment as well as hypothyroidism. So you would monitor this on a weekly basis at first, and then you'd move on to 2 weekly and then monthly, and then eventually 6 monthly. There's a protocol which you will have access to if you do have a psychiatry job. Okay, good. And you have to remember, so if a patient does come in with, let's say they are on lithium bipolar disorder and they've been having tremors and they've been having abdominal pain, so this will probably be in an A&E setting. You want to start them, you want to check their lithium levels pretty much immediately. So, and then if it's more than 1.2, that is, lithium toxicity is not uncommon, because lithium again has a very narrow therapeutic index. So lithium toxicity is something that you should be aware of, especially if you're working in A&E, for example, or even on psychiatry. I can just quickly, I don't have a slide for it, but I can just quickly, if you have a pen and paper, I can just quickly tell you the signs of lithium toxicity. I'll just give you a minute to grab a pen and paper if you don't already have that. Okay, fine. So I'll just go through some. So in the short term, lithium toxicity can cause fine tremor, muscle confusion. So these are the neurological side effects. It can cause a metallic taste in the mouth, nausea, vomiting, and diarrhea. These are the GI side effects. And it can cause a patient to drink more and pee more, so polyuria and polydipsia. This is because it can also cause diabetes insipidus, okay, and these are the endocrine side effects. And on the skin, it can cause acne, it can cause hair loss, and can cause edema. Okay, so that's your dermatological side effects. Okay, so now these are the side effects, okay? In toxicity, so this is when levels are more than 1.2, it can cause a coarse tremor. So remember the distinction. When it's just a side effect, so when it's not toxicity, it causes a fine tremor. If it is toxicity, it will cause a coarse tremor. This is again when your examination will also come in handy. Okay, if they have a fine tremor, it just means that they are probably on lithium. Okay, I mean, amongst others, there's a lot of things that can find tremors, but if they have a bipolar disorder history and if they are on lithium, the fine tremor is probably lithium. It can also be other things like salbutamol and hypothyroidism, but yeah. If it's a coarse tremor, that's when you're worried because it's probably toxicity. They can have bloody diarrhea for toxicity. They can have nystagmus. They can have myoclonic jerks and ataxia, dysarthria, and drowsiness. So these are some of the signs of toxicity. Okay, so coarse tremor, bloody diarrhea, nystagmus, ataxia, and dysarthria. I will probably maybe do this separate session, maybe toxicity, but you can let me know in any either in your comments or feedback if you do want a session on lithium toxicity. But I'll just give you one more point on toxicity. If they do have signs of toxicity, you also want to check what other drugs they're on, and if they've been recently started on any drugs. Inhibitors and NSAIDs, which are again very commonly used, they can precipitate lithium toxicity. They can interact with lithium and precipitate toxicity. So if you are querying toxicity, make sure to ask them, have they been on any drugs recently? Perfect. So that's a bit about lithium toxicity. If you have any questions, again, like I said, feel free to ask. But I think, that's the last slide for this presentation. So, like in all psychiatric conditions, always remember to take a holistic approach. So it's the biopsychosocial. It's been through some biological therapies. So that's your lithium and sodium valproate and your antipsychotics. Coming on to some help. Okay, so psychoeducation is very, very important. Psychoeducation is mainly when you educate the patient about the disease and about the relapses, about remission, about fact that they can have certain triggers that they can look out for. It's been shown in multiple studies to reduce risk of recurrence and relapse. Okay, it improves the patient of the illness, which can then improve adherence to the medication and also help them recognize the signs and symptoms of relapse. In my, like when I was on my psych job and I had a clinic, it was amazing to see so many patients come in and actually tell me, oh, this thing happened, and I think that might be a relapse, or I will have a relapse soon. So hence why I'm here, just for you to kind of assess me and see where I am right now, which is actually, and it's actually so good because it's so empowering for patients to finally take control of the disease and tell or like go to the doctor when they feel like the relapse is coming back on, and actually improves a lot. So yeah, psychoeducation is very important. CBT is, again, it can help a lot, and for some patients especially, they can challenge the grandiose ideas they've been having and help them understand why they are false and why they're not true. And it can also, again, help them understand the tree, very specific for different people. CBT is not for everyone, especially because groups, I mean, it's very difficult to get individual CBT slots. So it mainly takes place in groups, and many people are not comfortable or may not be comfortable sharing their illness experience. But yeah, it's good to offer them anyway, because it can help. Therapy can be important for patients living with their families, and just to kind of, because as you can appreciate, it can be very difficult as well to cope with this illness, because I mean, when the relapse is ongoing, the patient might lack insight into it completely, but it's a family who will bear the brunt of it. So it's important to remember that the patient is part of a community, and then also to take into account the family's difficulties and how they're coping, to make them understand that the patient is going through this illness and it's not in their hands, and all their behaviors might not be in their control at that time, right? You can offer that as well. And then always remember, there's a lot of support groups out there. So there's a few I've just put: Mind and Sane, which is really, really useful in providing leaflets and support information, and just kind of a support group for them to talk about their experience when they are in remission. Fine, so that's everything. I did not fill this, and let me just add the links. So I think I will just backlink in now. If you guys can just fill in the feedback. Yeah. I think it's also on the Facebook group. So yeah, if you guys could fill in the feedback, and I will add the Zoom details in just 1 second.